Alright, let's talk about renovascular diseases. Unilateral or bilateral renal artery stenosis. Either could be unilateral or bilateral. That RAS, renal artery stenosis, leads to decrease in renal perfusion, which causes increase in renin, increase in angiotensin, and hypertension. Most common cause of secondary hypertension in adults. Okay. So here's the point. You have decrease in renal perfusion. Why? Because you have stenosis of the renal artery, causes decrease in renal perfusion, leads to increase in renin. When the renin comes, leads to hypertension. Okay. Now why did the stenosis occurred? Well, because of the cause of renal artery stenosis is either you have atheroseclerotic plaque, which is in the proximal 1/3 of the renal artery. So if you have atherosclerosis, that's gonna affect the proximal 1/3 of the artery, usually in the older males, smokers. And the second cause is the fibromuscular dysplasia. Fibromuscular dysplasia, which affects the distal 2/3 of the renal artery or segmental branches, but seen classically in young middle-aged females. Okay, so fibromuscular dysplasia, I'm going to talk about a little bit because this is a relatively important topic. So fibromuscular dysplasia, it is, first of all, it is non-atherosclerotic disease in which there is an abnormal tissue growth within the arterial wall. Okay, and that can involve any artery, but typically, so this growth can involve in any artery, but typically it involves the renal artery, the cerebral artery. In cerebral, we're talking about a carotid, or the vertebral arteries, renal artery, and the mesenteric or the extremity arteries, mesenteric extremities arteries. So if you were to involve the carotid or the vertebral artery, you will develop headache, stroke, aneurysm, rupture, right? And if you were to involve renal artery, you are going to cause renal artery stenosis, and resistant hypertension. And if you were to involve in the extremities or in the mesentery, you can develop claudication. So on the histopathology of fibromuscular dysplasia, you will see presence of fibromuscular webs, fibrotic webs, which leads to luminal narrowing, luminal stenosis, and alternating areas of aneurysmal dilation with loss of internal elastic lamina. Sorry, let me see. Here's the vessel. So you have aneurysmal dilation because of the loss of internal elastic lamina and the presence of the fibromuscular webs, which will give you a sting on a bead appearance, right? So if you were to do angiography, you will see string of beads appearance. Okay, so that's all what we have for fibromuscular dysplasia. Okay, now let's talk about here for unilateral. Renal artery stenosis, affected kidney can lead to atrophy, lead to asymmetric kidney size, right? Because it's only unilateral. Whatever is affected, there's a stenosis that causes that kidney to go into atrophy, which causes asymmetric kidney size because the other is normal and this is atrophied, right? Renal venous sampling will show increase in renin in affected kidney. Because the affected kidney needs more blood, it's going to cause increased renin secretion from that kidney. So you will have an increase in renin from the affected kidney, decreased renin in the unaffected kidney, very important also, because the other kidney is normal, it doesn't need no renin, so it's not going to secrete renin. That's only with the unilateral. But now let's talk about bilateral RAS. Patient can have sudden rise in creatinine after starting ACE inhibitors. You give ACE inhibitor, you inhibit the renin angiotensin-aldosterone system. The kidneys are not getting enough blood because of the renal artery stenosis, so the creatinine is going to rise due to ACE, ARBs, or renin inhibitors, because these drugs interfere on RAS-mediated renal perfusion. Okay. Third thing, can present with. Now, all of the renovascular disease or renal artery stenosis, it can present with severe refractory hypertension. Refractory hypertension, no matter what drug you're giving, there's a refractory hypertension. Flash pulmonary edema, epigastric flank bruit. Okay, and present with patients with RAS may also have stenosis in other large vessels. And we already talked about other large vessels being cerebral, carotid, vertebral, mesenteric, extremities, all of them. So what are the risk factors for renal artery stenosis? Let me actually go ahead and write these down. What are the risk factors for renal artery stenosis? How can you develop it? Well, smoking, diabetes, hypertension, other atheroseclerotic diseases, or the diagnosis of them, for example, coronary artery diseases or carotid stenosis. If you have RAS, renal artery stenosis, grossly what you can see on the kidney, that's the shrunken atrophic kidney, but histopath would show crowded glomerular tubules, which will be atrophied, interstitial fibrosis, and focal inflammatory infiltrates. As we talked about, we are going to be cautious using ACE inhibitors, ARBs, or any renin inhibitors with bilateral RAS, as these types of patients depend upon efferent vasoconstriction by the angiotensin II to maintain their GFR. So because you bilateral RAS, they depend upon the efferent vasoconstriction, so they can increase the GFR and maintain the perfusion. But if you were to inhibit it, then you can maintain GFR, you can maintain perfusion, leading to ischemia. I hope I'm making sense here. But let's look at this picture. You have the proximal 1/3. We said that's atherosclerosis. Distal 2/3. And we said that is due to the fact that we have the fibromuscular dysplasia. Well, in any case scenario, when you have the renal artery stenosis, you are going to release renin. Angiotensin will cause vasoconstriction and hypertension and sodium retention. So that's a simple image. Okay, that's all we have for the renovascular disease.